During the Korean War in the early 1950s, thousands of United Nations soldiers stationed near the Hantan River were halted by a mysterious pathogen. They developed severe fever, acute renal failure, and generalized hemorrhaging. Decades later, in 1993, a very different clinical presentation emerged in the American Southwest. Instead of kidney failure, patients in the Four Corners region rapidly drowned in their own lung fluids, succumbing to acute respiratory distress. The World Health Organization categorizes these distinct outbreaks under a single emerging zoonotic threat, hantavirus. The stakes of infection are severe. Depending on the specific viral strain, case fatality rates range from less than 1% up to 60%. Medical science currently offers no targeted antiviral cure, and there is no universally approved vaccine. These are not new diseases. Hantaviruses are ancient pathogens that have circulated in rodent populations for millennia, only recently colliding with modern human populations in lethal ways. Hantaviruses belong to the order Bunyavirales. They are enveloped, single-stranded, negative-sense RNA viruses. This diagram shows the macrostructure of the virion. A lipid envelope forms the outer boundary, enclosing and protecting the genetic payload inside. That payload is a tri-segmented genome. The small, or S segment, encodes the nucleoprotein, which wraps around and shields the viral RNA. The medium, or M segment, provides the blueprint for the GN and GC glycoproteins. These form the spike complexes projecting from the envelope, which the virus uses to bind to and enter host cells. Finally, the large, or L segment, encodes the RNA-dependent RNA polymerase, the critical enzyme the virus needs to replicate itself once inside the host cytoplasm. Viewed through an electron microscope, these spherical and pleomorphic particles can be seen clustering together as they hijack the cellular machinery. This tri-segmented architecture is the result of millions of years of coevolution. It allows the virus to survive and replicate harmlessly within specific rodent reservoirs, establishing a biological baseline that becomes disastrous when introduced into a human host. Viral outbreaks follow predictable ecological cascades. Sudden spikes in human infection are consistently triggered by macroclimate anomalies, such as the El Niño Southern Oscillation. Heavy rainfall in semi-arid environments causes a resource pulse. Months of precipitation abruptly transform dry landscapes, creating a massive explosion of vegetation, seeds, and insects. This superabundance of food skyrockets the environment's carrying capacity. Freed from resource limitations, local rodent populations boom, reaching densities many times greater than normal. As rodent density increases, so does social contact and territorial fighting. This initiates an epizootic phase, where the virus spreads rapidly through the hyperdense population. Epidemiologists calculate the hazard of a human spillover event using a specific equation. Risk is proportional to the rate of human-rodent contact multiplied by the density of the rodent population, multiplied by the virus's prevalence. During the 1993 Four Corners outbreak, the rodent population tripled, and viral prevalence increased by 50%. Combined with increased human contact, these variables multiplied to create a staggering 9-fold increase in human infection risk. The path to a lethal human outbreak is locked in months before the first patient shows symptoms, initiated entirely by shifting global weather patterns. Hantavirus transmission rarely occurs through direct rodent bites or the consumption of contaminated food. This diagram illustrates the true primary route of infection, the inhalation of aerosolized viral particles shed in the urine, feces, and saliva of infected rodents. Entering enclosed, poorly ventilated spaces that have been infested by rodents directly facilitates this transmission. The physical mechanics are straightforward. Dry sweeping pulverizes dried rodent waste, launching a highly stable viral payload into the breathable air, drawn deep into human lungs.
In the rodent reservoir, the infection is chronic, persistent, and peaceful, resulting in lifelong viral shedding. In the human body, the infection is violently acute and incredibly short-lived. Because the human infection is so fast and destructive, patients do not shed the virus into the environment. Humans act as biological dead-end hosts, contributing effectively zero to the environmental viral load. This map divides the hantavirus family by geography, revealing a strict split in how the virus attacks the human body. Old World hantaviruses, across Europe and Asia, are hosted by murinae rodents. In humans, these strains show a strict tropism for the kidneys, causing hemorrhagic fever with renal syndrome, or HFRS. New World hantaviruses, found in the Americas, are hosted by sigmodontinae rodents. These strains show a tropism for the lungs, resulting in hantavirus pulmonary syndrome, or HPS. Following inhalation, diviral GN and GC glycoproteins bind tightly to the endothelial cells, the thin layer of tissue lining the inside of human blood vessels. The clinical pathology presents a paradox. The virus itself does not directly destroy the lung or kidney tissue. The damage is caused by immune-mediated endothelial dysfunction. The human body's massive overreaction of inflammatory cytokines attacks the infected capillary walls, causing them to break apart and leak plasma, allowing fluid to pour out into the surrounding tissues. Geography dictates the rodent family, which dictates the viral strain, which ultimately programs the human immune system to destroy a specific internal organ. This timeline compares the clinical trajectories of the two syndromes. HFRS is a prolonged ordeal involving 5 distinct phases: febrile, hypotensive, oliguric, diuretic, and recovery. The patient experiences dropping blood pressure, internal bleeding, and a dangerous halt in urine production as the kidneys fail. HPS follows a much shorter path. For the first 3 to 5 days, patients experience a deceptive flu-like prodrome. They suffer from fever and muscle aches, but a cough is notably absent. This is followed by a brutal cardiopulmonary crash. Massive fluid shifts fill the lungs' air sacs, causing plummeting blood oxygen levels and life-threatening hypotensive shock, often in under 24 hours. Physicians have no antiviral cure to administer. They must rely on epidemiological history and diagnostic tools like PCR or serology, while the patient's vitals rapidly deteriorate. Survival depends entirely on aggressive ICU supportive care. This requires mechanical ventilation to force oxygen into fluid-filled lungs for HPS patients and intermittent hemodialysis to clear toxins for HFRS patients. Treating hantavirus is a race against the clock. Medical teams must artificially sustain the patient's vital functions just long enough for the deadly immune storm to burn itself out. There is one terrifying exception to the rule that humans are biological dead-end hosts. In South America, the Andes virus breaks the pattern. It is the only hantavirus definitively proven to transmit from human to human. When it occurs, transmission is typically localized within intimate household clusters, among close, prolonged contacts. Because medical treatment remains entirely reactive, the primary public health strategy is proactive, disrupting the interface between humans and infected rodents. Environmental decontamination requires strict adherence to protocol. You must never dry sweep or vacuum an infested space. The area must first be thoroughly soaked with a bleach or disinfectant solution to weigh down the viral particles and neutralize them on the floor. When cleaning sheds, cabins, or agricultural areas, the use of high-grade respiratory PPE is an absolute necessity to prevent inhalation. Hantavirus exposes the severe vulnerability of the human immune system to aerosolized pathogens. Mastering this entire chain of events, from the ecological triggers to the molecular